Is it good? Wait. Okay. Can't you see the screen?
Yes, we can see your pointer and your 3D volume rendering too. Thank you.
Okay. Maybe I will start with the 3D volume rendering first. So this patient actually come to our department with the suspect of bronchiolitis. So the patient said, I'm sorry, the clinician said to us because the patient always have infection, lung infection. So this is actually not really related to the congenital heart disease, but this is interesting because not only in the congenital heart disease we can see some kind of this anomaly, but not in the
I think we're having some connection issues, unfortunately. Yeah, probably have to. It seems like Dr. Amal got offline. Sorry about that, people. See, Dr. Kadala. Hey, where are you calling from? Kadala?
Yes, Prof, I'm from Tanzania.
Excellent.
KCMC,
From
yes, KCMC.
KCMC. All right.
Yes,
Beautiful town of Moshi.
yeah.
Yeah, very nice. Dr. Amal is back. Thank you.
Sorry, I
No
think
worries.
my connection is not okay. Okay, I will share again the case. Wait. Okay, wait, Prof. I think. Prof, I think it might be need a little bit more time because
Like a reboot or something?
my
Like
connection it's yeah.
Okay,
Sorry.
no problem. Would you like me to show a case in the meantime? Maybe?
Sure, Prof. Sure.
Okay. I will go ahead and share my screen then. Hopefully you can see it. So, like Dr. Amal said, this is indeed an important thing to keep in mind for all of us cardiovascular imagers and specifically pediatric radiologists, that a lot of the patients with congenital heart disease will come in with either recurrent respiratory infections or airway problems or suspected asthma attacks or stuff like that. And sometimes it is an airway anomaly, but sometimes it is a cardiovascular anomaly. And I do believe Dr. Amal will show us some specific airway anomalies as well. The cases I have are more pertinent to cardiovascular abnormalities that have an effect on the airways. And it is therefore very important to keep in mind that sometimes these patients, though come with pulmonary symptoms, they might have cardiovascular abnormalities. In this particular case, let's try, if just for giggles, if you guys can find in the bottom left corner of your screen the annotate button and put an arrow on the abnormality here. I already put an arrow on it, but I'm just testing the system for a second. Just want to see if we can make this interactive. Not a lot of people are able to do that. That's okay. Dr. Aldi, thank you. All right. So, Dr. Yogi. Hi, Dr. Yogi. Okay. So I'm going to scroll through the pictures here. Because the story with this child was, who was at the time, I believe was, actually it's like a 19-year-old patient. As you can see, we have a right-sided aortic arch. We have a left brachiocephalic artery, that then splits into a left common carotid and a left subclavian. We have a right common carotid and the right subclavian coming off the aortic arch. So this is a right arch with mirror image branching. But we can also note that in the proximal descending aorta, we have a little diverticulum here that really looks like at some point it used to want to connect to this, what we now call a left brachiocephalic artery. If I do it in a MIP, you can actually see a little bit of like sort of a calcified remnant of this left-sided aortic arch. And as I'm sure most of you know, developmentally, we all start out in our mother's wombs with two aortic arches, and one of them regresses. And sometimes it's the left side that regresses, and then you end up with a right-sided aortic arch, or you can end up with funny anomalies of the subclavian arteries. But that's the embryologic history here, that sometimes some of these arch branches can take varying courses. In this case, we have a double aortic arch with an atretic left arch. And that creates a vascular ring, which is exactly the spot where this tracheal narrowing is. If you look at this particular image down here, and we put it in a minute, which sometimes is helpful if you're able to do that, to visualize the airways better, you can see that that focal narrowing of the airway is exactly at the level of that aortic arch and that double aortic arch. So this is kind of a warm-up case, just showing you a relatively simple case where really the only anomaly we have is a right-sided arch with mirror image branching at first glance, and then at closer observation, we can see that there's a little diverticulum. So there is an atretic left-sided arch as well, which completes a vascular ring because this ligamentum, this atretic left-sided arch, completes the vascular ring in this case. Patient had no other anomalies. And the tracheal narrowing is relatively mild here. Depending on the symptomatology, the surgeons may or may not elect to operate on this child. The other issue that this can cause is also obviously dysphagia if the esophagus is also compromised. So we have a double aortic arch with a left-sided atretic limb and mild airway compression. Dr. Amal, you think we can move on, or what should we do next?
Yes, I think I try to share my screen again.
Let's do that. Thank you.
Okay. Thank you, Prof. Pal.
My pleasure.
Okay, we'll share again. Okay. Okay, can't you see the, wait, stop share. Wait. Room. Okay, I will, okay. I think because of the volumetric rendering, it's not quite good. I will share the 3D MPR. Is it okay? Sorry.
I think that's fine.
Yeah. Okay, so yep. Can you see my screen, Prof?
Yes, we can, and your arrow as well.
Okay, great. Sorry for the technical issue. So yeah, this patient actually have a suspicion of the lung infection, but suddenly we found something interesting in this patient. So yeah. Oh, okay, I will continue. So when we see the CT scan from the axial projection in here, we can see the anomaly of the lungs, and also we can see clearly the vascular great arteries, great vessel in here. In here we can see this is the aortic arc. I will show with the arrow. This is the aortic arc, and then when I scroll down to the caudal part of the area, we can see there is this is main pulmonary artery, and also this is the left pulmonary artery that circle the trachea from the posterior. So this is the case of the pulmonary artery sling. Actually, this is left pulmonary artery sling. And also, when we scroll down again to the caudal part, in here we can see this is the right pulmonary artery. But since the lungs have anomaly, so this is the hypoplastic of a right lung. So with the left pulmonary sling in the posterior. But the more interesting about this patient is it's when we have imagination, so it's like a spiral moving of the vascular around the trachea. First, in here, we can see this is the left-sided aortic arc, but in here, this is the subclavian artery. So it's like aberrant subclavian of the right. So there is a right aberrant subclavian, and also when we scroll down, this is the left aortic arc with left descending, with the right descending, sorry. So this is left aortic arc with right descending. So this is also cause the tracheal stenosis because of the vascular in the posterior of the trachea. This is the right descending aorta. And then next step to the caudal, we can see also the left pulmonary sling. So this is quite difficult patient because not only left pulmonary sling caused the stenosis of this trachea, but also because of the left-sided aortic arc with the right-sided descending aorta. So, and also in the cranial part, there is also right aberrant subclavian artery. So, next, the patient will not only have airway disturbance, but she will also have like dysphagia usually because of this right aberrant subclavian artery. So not only about the vascular we need to explore in here, but we need to also expertise and evaluate the trachea also, because majority case of pulmonary sling or aortic ring, the trachea will also have anomaly, such as full cartilaginous of trachea, full ring of the cartilaginous of trachea. Usually, as we know, the cartilaginous trachea is like a C shape with the membrane in the posterior. But in the case of pulmonary sling, we can see here the trachea is quite circle. So we need to aware and be careful about this trachea, because this patient might have full cartilaginous trachea. So the surgeon needs to know not only the treat, they make adjustment of the vascular or the great artery, but they need to make sure about the trachea. It's to release the stenosis, because if the patient only undergoes the surgery of the vascular, but the trachea, full cartilaginous trachea or trachea stenosis not released, the patient will have same symptoms with the airway disturbance. So this is the unique of this patient. Then I will show the coronal. So as we can see here.
In the meantime, I just wanted to interject. It's really fascinating because the two great vessels kind of crisscross around the airways, right? One goes from one side, one from the other side. It's really crazy in that sense.
Yes, that's true. So here it's yeah. So
there almost seems to be no airway on the right side, but we have some aerated lung. So that's interesting on the right side. Is that how does that lung get any air?
It's from actually lung. It's from it's from bridging. it's bridging bronchus actually. So the bronchus that goes to the inferior lobe, it's not directly from the carina, but from the branch of the left bronchus, proximal of the left bronchus. So yeah, here you can see my arrow.
Oh my goodness, that is crazy.
Yeah. So yeah, this patient, it's really difficult for a surgeon, and also
so in that case,
difficult.
though, the question almost becomes is that part of the left lung maybe and just moved over, no? That there's complete
but
aplasia of the right lung versus hypoplasia. I mean, if there's
actually, first I thought this is the aplasia of the right lung, but when I see the axial, and also I see the branch of the right pulmonary artery in here. So yeah, I thought this is not the
that's more likely to be
yeah. So this is the right pulmonary artery here.
Yeah. I think
So
you're right.
that's
I
why
think you're right. Yeah. Very cool.
That's why I'm thinking this is the hypoplastic of the right lung. But yeah, this is the one of the cases that really interesting. It's like
let's talk a little bit about
Sling.
Yeah, it's very, very interesting. Let's talk a little bit about those two additional areas in here. One in the left upper lung anteriorly, or left lung, maybe it's the upper lobe. There seems to be some loss of aeration, maybe some consolidation. And then there's a big soft tissue to the right of the mediastinum, which probably just going to be thymus, but I bet some people would like to know what's going on in the actual lungs, because to me it looks like that left-sided lung that's not aerated is partially enhancing, partially not enhancing. So some of it is probably atelectasis, but some of it may be actually infection. If you scroll further down, yeah, right there. So it may not just be atelectasis, is what I was wondering.
Yeah.
And on the right side, is that thymus? On the right side, is that collapsed lung, or is that thymus?
In the upper lobe, upper part of the hemithorax. Probably this is still thymus or mediastinum part.
But see how it's different? It almost seems like it's yeah, interesting.
Yeah. That's the
wow.
First case.
Can you scroll through that on the corona one more time, please?
Sure. We'll give the MIP. Wait.
And you were saying that there's no additional cardiac anomaly, right? Just the great vessels are funny.
No, yeah. Okay. Okay, yeah. This one. There's also dilated of the azygos vein in here.
Oh, I see. So that very hyperdense thing on the right side was just a dilated right atrium and the right atrial appendage that I was looking at.
Yeah.
So that's okay. That's the right atrium. Above it, you have a little bit of thymus, I guess. Okay.
Yeah, indeed.
Yeah. Okay. And as you come more and more anteriorly, yeah.
This is, I'm going to the posterior side.
Oh, now you're going posteriorly. Yeah. Mhm.
This is
And then
to the
come back
anterior.
anteriorly. Yeah. The appendages, but see that left upper lobe area is very. Could you come all the way anteriorly, like to the sternum almost?
This one, I think there's
Yeah,
some parts of
that's very
infection.
patchy. Yeah, yeah,
Mhm.
probably. Keep coming anteriorly. Yeah, the heart looks pretty good. Obviously, rightward shifted because of the hypoplastic right lung. Wow. Does anybody else have any questions from online?
Yes.
You can speak up or
That's one of the interesting case.
type it in the chat if you have questions. We will try to answer them.
No question?
I
Okay,
don't see a
so
question. You can ask questions later too. Okay.
yeah. Okay, so actually, I want to share my experience because sometimes in my country, the clinician always asks if there's infection, thoracicity with contrast. So before we did the contrast, we need to know what's the reason or about the history of the patient. So that's why in this patient, the contrast in the vessel or in the artery, in the pulmonary artery, and even in the vein, it's very bright. So we use angio technique for this patient. So not only usual or standard thorax or lung CT, but we adjust to the angio of the thorax. So that's why we have clearly a good image of the vessel also. That's the experience that we have
that's an important
in
point.
our hospital.
And also because of what we discussed, that not only does it give you a better visualization of the lung parenchyma, but also the vasculature, yeah.
Yes. Okay. Another patient?
Yeah.
Okay, I will share again. So, okay. This is one of anomaly that we sometimes not common, but some patient also have this kind of anomaly. So we call it the tracheal bronchus. So as you know, so this is the patient with the tetralogy fellow come to our department to do the CT cardiac, but I found interesting about the airway. There is a early branch of the right upper lobe lungs. So the branch is directly from the trachea. Usually, the normal patient, we can see the branch of the right upper lobe is from the proximal of the right bronchus, but this patient is directly from the trachea. We need also to inform this to the clinician because when they put endotracheal tube, they need to know how deep the endotracheal tube. So that's why we need to inform about the range of this tracheal bronchus from the carina, because when they insert endotracheal tube, near to the carina, this lobe will collapse or will have atelectasis. So that's why we need to inform also about this anomaly and how long, or about the range, the tracheal bronchus from the carina also. Yeah, this is the volume rendering in here about the tracheal bronchus. I think that's the second patient. So is there any question?
I have a question.
No. Yeah, please.
So, is there any report that tracheal bronchus going to the left side, or it's only on the going to the right side?
Excellent question.
Oh,
I don't think I've ever seen it. Good question.
yeah, also. Yeah.
Has anybody seen it?
Really? No, in my experience, no, I haven't seen the tracheal to the left lung, but we have like a different type of the tracheal bronchus. So it's like segmental. So it's only a segment, or it's lobe, part of the upper lobe.
Lobar.
So yeah,
Yes.
we lobar tracheal bronchus or segmental tracheal bronchus. But to the left side, no.
Maybe in somebody with situs inversus.
Probably.
Yeah, I've never seen it. Yeah. Very cool.
Yeah, I think that's 2 patient for me. I think next you can share your patient, Prof. I will stop sharing.
Can you tell me one thing? If just for no, did you see my mouse while you were presenting?
No.
Because I was trying to point to see if the interactive version, maybe the interactive things don't work as well in Zoom, or we'll just have to figure out how to use them. All right, so I'm going to go ahead and show you a couple more cases. This almost looks like it's the same case, right, as previously. Very, very similar focal narrowing of the trachea. One thing that I would caution everybody with is the 3D is very, very helpful and very, very important to look at. But it's also important to turn the patient, because sometimes the narrowing is going to be more apparent if you turn the patient. See, here we're looking from the left, and here we're looking from anteriorly. So here we can see that this patient actually has a much more pronounced severe stenosis of the trachea, not just in the frontal view, but also in this view. So that trachea is going to be really, really narrowed. And the other thing is, when we're looking at patients on the 3D reformat and we see some abnormalities, it's always important to go to the source images and verify if that finding is really there, or are we just being fooled by the fanciness and the colors of the post-processing. So in this particular case, in this child's case, you can again see the trachea getting very, very narrow. Like Dr. Amal said, I'm going to reiterate that because that was an excellent and very, very important point to look at the morphology of the trachea. In this case, you have a C-shaped cartilage anteriorly and the posterior more membranous portion that's flimsy. But as you scroll down, right here, the trachea gets extremely narrow. So again, it's helpful to co-register your images and see where that narrowing is in this in the other views. And notice also that if I'm just scrolling through the coronals, it's kind of almost, it would be easy to miss that focal narrowing. So very important to look at both the 3D, like Dr. Amal was showing us, and also the different projections. And make sure you look at it and think about it in both dimensions or all dimensions. In this patient's case, if you look at the vasculature, however, I'm going to MIP it so everybody can more easily follow the vasculature. We have the aortic root here with a left coronary artery, ascending aorta, right brachiocephalic artery, giving rise to right common carotid and right subclavian. That's normal. We have a left common carotid artery, and we have a very nice left subclavian here. And then there's a mild narrowing here of the distal aorta at the isthmus, but nothing major. But then if I switch this image, that's a MIP, over to a MINIP, and then I'm going to switch it back to a MIP again. So the narrowing is right here. See what's right here? It is our brachiocephalic artery. And if you look at this axial view, again, coming from the top, from the apex, we see our trachea gets very, 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 very narrowed. And the narrowest point right here is exactly at the crossing of that right brachiocephalic artery. So in this patient's case, the reason for the tracheal narrowing and the pulmonary symptoms and recurrent infections or asthma, I don't remember exactly the story. This was a couple months old child at the time. I was just checking the age. Was caused by the brachiocephalic artery. So it's very, very important. You can see this in this volume rendering, the pink trachea and the right brachiocephalic artery causing this indentation on the trachea right there. The innominate artery, also called right brachiocephalic artery, compressing on the trachea. This is kind of looking from the right side. You can see that there's an AP compression as well, right at the level of the innominate artery. So this can be surgically corrected by actually taking the innominate artery from the arch and moving it further down. So this can be helped, but like Dr. Amal mentioned it earlier, extremely important to look at the trachea morphology as much as we can tell to see how likely it is that the surgeons removing the vascular ring or vascular compression will actually help the child. There's another thing that they can do, obviously, with bronchoscopy. They can look inside the airways and examine the morphology of the trachea, the completeness or the C shape of the cartilaginous rings. So that's the next case I had. Any questions right here? If there are no questions, then I'm going to...
I have
Yep, go ahead.
a question, Prof.
Yes.
Yeah, when I look this patient from the axial image, we can see
Yes.
the distance between the manubrium sternum and the brachiocephalic artery. It's quite big.
Yeah.
I'm not so sure. Is there any like the hypodense structure? Usually, when we see the patient in the axial image, usually the brachiocephalic, also the innominate vein, it's near to the manubrium sterni.
Yes,
So
that's true. Is there some chest wall deformity? Is that what you're wondering?
Yeah. So
maybe
the distance is
but
quite
there's this big thymus there too. Although I will
yes.
say that yeah, there's no compression of the innominate vein. So I don't think the vascular compression is from this. Were you worried that
Yes.
there's maybe a mass or something?
No, because if that's a thymus is very soft, then
Yes.
the innominate
That's
vein it's
true.
not compressed, but the location, I mean the position of the brachiocephalic, it's to the posterior. So
Yes. I
that's
don't know. I mean, you can see this. I'm doing this MIP.
Mhm.
It doesn't look like there are any like pectus carinatum or anything like that. Or
Yeah.
I'm not sure. We can also try 3D to look over the chest. I don't know. Doesn't. Yeah. Yeah. So I think the issue is just kind of a late takeoff of the brachiocephalic artery. That's it gets very close. Yeah. I'm not sure. Do you have any other thoughts?
Yeah, because I have also experience with the not the same but similar, but because of the distance of the manubrium and the ascending aorta, it's quite large, so it causes compression to the airway. And also I've read one of the publication about the bronchial compression, actually by the posteriorly displaced of the ascending aorta. But this patient, it's
So
more perennially. So yeah.
yeah, you also can have like a cervical aortic arch, right? When it goes up there. But I think this is the level of the thoracic inlet because of the clavicular heads and the first rib. So
Yeah.
I don't think that this arch is cranially displaced, but we can. Yeah,
It's nice.
interesting. All right, let me check the Zoom chat. Okay. This next case I'm going to show just in 2 seconds, just another example of that pulmonary sling, sort of similar to Dr. Amal's case, but not as bombastic, not as amazing. But we have here a left pulmonary artery coming off of the right pulmonary artery, coursing around the trachea. And you can see that the trachea is kind of diffusely small in caliber, even higher up. And then distally, where the pulmonary artery is going around it, it becomes very, very small. And very importantly, we have to pay attention not only to the trachea, but also to the other airways, where we can see here that the left-sided left main
of the heart
is essentially completely occluded. You can see it also on the 3D rendering here. So not only do we have an issue with the pulmonary sling in the distal trachea, where actually even morphologically it's questionable if we have rings. I think it's kind of a flattened trachea, so I think this is still, it looks like it's probably a C-shaped cartilage. It's not a round trachea, thankfully, so that gives me a little bit of hope. But for whatever reason, the left main bronchus is also compressed, and it may very well be because of this pulmonary artery sort of coursing downwards posteriorly along with the heart causes some obstruction. I'm going to show you the sagittal view. Like we said, it's very important to look at these in multiple orientations. Even if you don't have the ability to do 3D volume rendering, look at it in the coronal and sagittal and axial views and try to piece it together. You can see that the distal trachea is narrowed, and then you get into the left main bronchus, and it gets super narrowed here at the level of this pulmonary artery. So as it courses along the pulmonary artery. One of the issues might be also that you can deal with bronchomalacia, like that the cartilage is there, but it's weak. It's another potential issue in some of these children. So very important to keep those things in mind. A couple additional cases here, just 2 cases back to back with, actually I have 3 cases back to back that are all tetralogy cases demonstrating variations on pulmonary artery enlargement and consequent compression on the airways. This patient is actually a 35-year-old patient, where you can see on this 3D volume rendering that there is significant compression of the distal left main bronchus, or the right main bronchus, the bronchus intermedius, and the right upper lobe. Lobar bronchus is completely occluded. Now, I mentioned that it's important to look at these in 3D. So you can see also posteriorly, hopefully you can make it out that there is a C-shaped cartilage here, but the cartilage appears to be a little bit flattened, both in the trachea and in the mainstem bronchi. So we have a little bit of tracheobronchomalacia. The sort of the normal morphology of the trachea should be more like this, where even if you have kind of flattening or a little bit of anterior movement of the membranous portion of the trachea, you still want the cartilages to be C-shaped. So definitely we have a big problem here on the right side. Now we're going to go to the axial images. You can see a nice C-shaped tracheal cartilage here with the membranous portion posteriorly. And as you get into the distal trachea, things are flattening out. But the left main bronchus still remains of normal caliber. And the right main bronchus gets very, very, very narrowed, almost down to nothing right here. And then bronchus intermedius still flat, but then you have the right middle and lower lobe bronchi that are fairly decent in size. And you can see that the compression of that right main bronchus happens right where we see this marked right pulmonary artery enlargement. We can also see a little bit of a narrowing, or not a little bit, but moderate narrowing of the proximal right pulmonary artery. So this may actually be sort of a post-stenotic dilation. And then watch the upper lobe airways here. These are the upper lobe airways. These are the segmental airways of the upper lobe. This is the right upper lobar bronchus. Watch this, it gets completely occluded. So that's exactly what we saw here on the 3D volume rendering. And this is a 35-year-old, like I mentioned. This patient already underwent palliation for tetralogy of Fallot with a transannular patch that you can see here, the calcifications in the RVOT and at the level of the pulmonic valve. So this patient has, we don't see pulmonic valve tissue, so probably the valve was also resected. So this patient has severe pulmonic or free pulmonic regurgitation, hence the markedly dilated right heart, very, very large right ventricle. But we can also see narrowing of both proximal pulmonary arteries with sort of a post-stenotic dilation of the branch pulmonary arteries, both sides. So this unfortunate patient's right heart had to suffer not only the increased volume overload from the regurgitation, but probably also increased afterload from these narrowed pulmonary arteries, and developed this markedly dilated right-sided pulmonary artery that led to airway compression. So just scrolling through the same patient in the coronal view coming from the sternum, we have this markedly dilated right ventricle with also very prominent trabeculation and very prominent muscle bands that would indicate that there is not only dilation here, but also some degree of eccentric hypertrophy. As we get nearer to the RVOT up here, we see the transannular patch with calcifications that it's extended to the proximal main pulmonary artery. We have a little bit of remnant valve tissue here, and then we get into the pulmonary arteries. On the right side, we have this focal stenosis here, and look at this left-sided pulmonary artery that's very, very, very small. So this was an adult with tetralogy of Fallot. Let me show you two more tetralogy cases. This is a newborn child where we have these fancy 3D volume rendering images. You can immediately see that both sides, both airways, are significantly compromised. And as we're changing the volume rendering, you will see that the culprit is actually markedly and massively dilated pulmonary arteries. So this is a rare form of tetralogy of Fallot where the patients have no pulmonic valve. It's called absent pulmonic valve variant of the tetralogy of Fallot. So these patients will have the malalignment septal defects or large VSD, and they will have main pulmonary artery and branch pulmonary artery enlargement. Instead of stenosis, in these patients, the physiology is dominated by pulmonic regurgitation, severe pulmonic regurgitation. The pulmonary arteries get very, very big. Now, some of these patients will have really no visible valve tissue, and others will have some residual redundant dysplastic valve tissue. But if they have mainly regurgitation, then the pulmonary arteries will get enlarged. This is a good reminder for all of us that pulmonary artery enlargement does not only happen from stenosis and post-stenotic dilation, but pulmonary artery enlargement, it happens in a lot of patients from severe regurgitation as well, because the pulmonary arteries don't really know why the flow is increased or is apparently increased. Is it from turbulence, from a jet and stenosis and post-stenotic dilation, therefore, or is it from the effect of regurgitation, large volume regurgitation going back and forth, causing a lot of turbulence? The pulmonary arteries will just sense that there's a lot of flow, so I need to get bigger to accommodate for that increased flow. So you can see here beautifully that the exact spots where the pulmonary arteries are dilated is where we have our airway compression. You can see that both pulmonary arteries are dilated here, and we have this dysplastic pulmonic valve that is responsible for it. Let me show you guys the axial images. Just scroll through quickly. Coming from the apex, we have a right-sided arch. Arch-sidedness is always determined by looking at the relationship to the trachea. So in some patients where you have collapsed lungs or hypoplastic lungs, things can shift left to right. It's important to remember that our anatomic landmark is not the midline. So it's not the line connecting the sternum to the spine, but it's always going to be the trachea to decide arch-sidedness. In this case, we have a right-sided arch. The airway is not narrowed up here in the trachea, but as you scroll down, you already start seeing these giant pulmonary arteries, and you can see that the left main bronchus almost goes to nothing here. The right main bronchus is also very severely compressed distally. The right upper lobe bronchus looks okay. The bronchus intermedius is very narrowed. And as you scroll down, you can see the right middle and lower lobe bronchi here. But definitely very severe compression on this left side. And then if you look at the arch branching, you have this vessel here coming up early. That is left common carotid. That is going to give rise to left common carotid. I think we don't have enough images going upwards. So I think this is actually an innominate artery. So this was going to be a right arch with mirror image branching, because from the distal arch, we only have a subclavian and the right common carotid coming. So I think this subclavian is probably connecting here. I can't prove it to you for sure, but this is probably a right arch with mirror image branching, which goes along with tetralogy of Fallot. It has a very strong correlation with tetralogy of Fallot. And like I said, in this particular case, though this patient was classified as a absent valve syndrome, tetralogy of Fallot, we can actually identify some valve tissue, but I think the deciding factor is what they see on echo, whether the physiology is dominated by regurgitation. And that was the case here. That in this particular case, we might have had some degree of stenosis, so don't let that alarm you. We can see the large malalignment subvalvular VSD, and we can see that the aortic valve, which is right here, overrides the interventricular septum and the septal defect. And we have right ventricular dilation and hypertrophy in this case, like I said, because we had both regurgitation and stenosis. 9-year-old patient, and then this is going to, or no, that was actually a newborn, like I said, and this one is a, so it's also a patient with an absent pulmonic valve. Again, you see some valve tissue, but don't let that deter you from calling it absent pulmonic valve. Large, very, very large pulmonary arteries. You can see the right pulmonary artery is going to compress on the bronchus intermedius here. So let me scroll up from the, coming from the distal trachea as we're scrolling down, carina right here. Right main bronchus, upper lobe bronchus takes off here. Then you get into the bronchus intermedius, which goes down almost to nothing due to this very, very large right pulmonary artery. And then you see the right middle and lower lobe bronchi here. On the left side, there's some compression. We do have a big left pulmonary artery as well, but the left main bronchus seems more normal. And you can see the left upper lobe bronchus as it's hyparterial on the left side. You can see the lower lobe bronchi here. So less severe airway narrowing, mostly involving the bronchus intermedius. Very dysplastic pulmonic valve with dominant regurgitation, large right ventricle with a little bit of hypertrophy. Remember that you will see a little bit of hypertrophy in these patients because the pressures will equalize between the left and right sided chambers because you have a non-restrictive VSD. A malalignment VSD is usually very, very large, and the pressures will equalize. So the right ventricle will experience systemic blood pressure. You see the aortic valve again overriding the ventricular septum, the ventricular septal defect. So this patient also had tetralogy of Fallot, and if you like volume rendering images, there you have again big pulmonary arteries with severe obstruction of the bronchus intermedius. Our time is almost over. I'm going to show you one more interesting case. Not sure if they do this sort of procedure in your countries, but this is something that I would anticipate that is a relatively simpler procedure, and this might be done in some of your countries. But this is a so-called hybrid procedure where this patient, who was obviously at that point a newborn, as you can see, we have a hypoplastic left heart. I believe the inciting event was aortic atresia. And if there's no flow, it won't grow. So since there was not a lot of flow to the left side of the heart, the left ventricle did not develop. You can even see that the left atrium is sort of hypoplastic, relatively small when compared to the right ventricle. And we're going to go around the circulation. We get out, we have aortic atresia, so we're trying to get out to the aorta, but there's no flow here. You can see the aortic root is very, very hypoplastic. You can see the right coronary and the left coronary there, and this very, very, very hypoplastic, very tiny ascending aorta, which in reality, in this child, is not really an ascending aorta, but it's a descending aorta because the blood flow is actually coming from this patent ductus arteriosus, and it's going to be backwards, downwards, flowing to the coronary arteries. So this ascending aorta is so tiny because its only use in this child was to provide circulation to the coronary arteries. So it's very much hypoplastic. We're going to follow the aorta. Now we have an aortic arch that's obviously fed by this ductus arteriosus, which also happens to have a stent. That's one part of the hybrid procedure. The hybrid procedure is called hybrid because it's done by cardiothoracic surgeons and interventional cardiologists in a hybrid fashion. There is endovascular and surgical intervention both. So this stented PDA is what is responsible for the development of the arch. And it seems like it's a left-sided arch with normal branching pattern. So we have a right brachiocephalic or innominator artery, right common carotid, right subclavian, left common carotid, and left subclavian branch here. And then we have a narrowing here. So we have also a coarctation, obviously, which makes total sense with very hypoplastic ascending aorta. And then if you scroll down, the descending aorta seems to be of normal caliber here. So we've sent out the blood to the systemic circulation. Now we're going to collect it back through the hepatic veins, IVC, draining to a normal appearing right atrium. We have the SVC superiorly, draining to the right atrium as well. And we have coronary sinus that's hard to see. We also have a septal defect here. Looks like a primum type defect. And then blood flow, deoxygenated blood goes to the right ventricle through the tricuspid valve. And it's mixed in through this ASD, it's mixed in with the pulmonary venous return. So there's going to be purple blood, mixed blue and red blood going to this very, very large hypertrophied and dilated right ventricle, which is the only ventricle, so functionally a single ventricle that pumps into this giant pulmonary artery, main pulmonary artery, that then has rightward and leftward pulmonary arterial branches, and also provides flow through this stented PDA, the still patent ductus arteriosus, to the systemic circulation, to the descending aorta. Now, what did the surgeons do here? They put pulmonary artery bands. You can see one of the bands right here, a pulmonary artery banding is what this procedure is called. And this is the other side of the pulmonary artery band. They band these pulmonary arteries. They put elastic bands on it and size it so that they restrict the flow to the pulmonary arteries and allow the child to grow up for a more definitive repair. By restricting the pulmonary artery flows, you allow more flow to the systemic circulation so the child can grow, and also drop the pressure in the pulmonary arteries so that you can prevent the development of irreversible pulmonary arterial hypertension or pulmonary hypertension. And this is the hybrid procedure. So you have a PDA stent, you have this coarctation of the aorta, you have to remember this posterior shelf that the surgeons at some point will have to deal with. You have this very hypoplastic ascending arch. You have the bands on the pulmonary arteries. This is what the left pulmonary artery band looks like on 3D volume rendering. You can see, trying to find a better 3D, the pulmonary artery bands. You can see both pulmonary artery bands in this view. This is the right pulmonary artery. This is the left pulmonary artery band that restricts the flow. So getting back to the airways, because of this pulmonary banding procedure and the post-stenotic dilation of this right pulmonary artery, you have a focal narrowing of the bronchus intermedius. But the rest of the airways look actually fairly decent. And I do believe I had a 3D the airway. Well, I can create it. So just to orient everybody, this is the native aortic root with the coronary arteries. This is our hypoplastic ascending aorta. This is the PDA stent with the big pulmonary artery. This is the descending aorta. This is the left pulmonary artery band. And you can see the right pulmonary artery band is right here. That's where it's narrowed. And then if we switch this to the airway view, we can see that the bronchus intermedius and apparently the right upper lobe bronchus also. I missed that somehow in the axial. Let's see. Yeah. So we also have an atelectasis in this right upper lung. So that makes sense. This is the airways. And they actually don't connect. This is the origin of the right upper lobe bronchus, and it gets occluded there, compressed, and then the bronchus intermedius. So both the right upper lobe is compromised and the bronchus intermedius in this case. And it's all due to a giant pulmonary artery on the right side. All right. So sorry about the technical difficulties. If you have any questions, we'd be glad to answer them. Dr. Maleva from Florida has a question: what type of contrast protocol you use for the congenital cases? We usually use weight-based protocols and hand injection at our institution, but different institutions use different techniques. At our institution, always hand inject, and it's a weight-based dosing, and that's why we have fairly good opacification of both hearts, because it's almost like a venous phase acquisition. And so the preferred injection speed is going to be determined by the physician injecting. I do believe that Dr. Amal usually uses an injector, right? And power injection, right? Dr. Amal, could you comment on that, please? So just so you guys can hear different approaches. There's no really right way. We just have to be very careful with children and looking at the size of the IV and make sure that the IV is not blown. But if you do it carefully and in a smart way, you can use power injection, but I'll let Dr. Amal has more experience with that.
Yeah, thank you, Prof. Yeah, we use injectors for the cardiac scan. So we use like triphasic injection. So we mix the contrast with the saline flush. So yeah, we use the injectors, but for the type of contrast, we usually use the 370 or 350 milligrams per milliliters contrast iodine. And about the protocol, usually I try to tell to the technician or radiographer to do the scan time manually. So when we see the contrast fill or both of the chamber of the ventricle, then we start the scan. But we need to make sure also about our scanner, because we have like two different scanner. So we need to know about the fast, I mean, how fast the scanner will capture the image when we press the scan button. So that's also we need to calculate. So I think that's our protocol.
Mm-hmm. And have you calculated the contrast dose you use?
Oh yeah, by weight, same with you. So
Yes, and what
I
you
use
maybe, yeah.
Yeah, 1 or 1.5, but for the Fontan procedure, I will use like 2 or even 3 milliliters per kg. So that's
Yeah, so 2 or 3, is that what you
yeah,
said? cc's per kg. Mm-hmm.
yes,
Yeah.
but that's for
Yeah.
the Fontan, yeah, Fontan study, and different protocol also for the Fontan.
Oh, okay. So you give more contrast for the content because you want a
Fontan,
more delay, right?
yeah, different different protocol also. So I use two IV lines. So I need to make sure the delay phase.
Oh, so
So
from below, from
like
the
two,
and above.
yeah, two injectors. One using hand, one using the injector. So it's like that
Ah, okay.
combination.
Okay. Yeah, in our institution, cardiologists, pediatric cardiologists hand inject most of the time. You know, if the children are older, like teenagers or young adults with congenital heart disease, then we use power injection as well. And yes, it's very important to think about the timing as well. That's a very good point. In like Fontan patients, we have an arterial phase and then we do like a 2-minute delay. What delay do you use for the delayed phase in Fontan?
Same. I tried both. I think I tried everything, but the result is it's almost the same. The result, yeah. I tried the delay, and then I tried the both IV line. So it's depends on the patient condition. So when the nurse or the anesthesiologist confidence to do the both IV lines to the patient, then I use that protocol. But if they say it's difficult to find the access of the IV line, then I use the delayed phase, same with you, like 2 minutes delay.
Mhm.
But I use the power injection, so I need to make like a 3-phase protocol. So I will make the third phase. It's like first, second, and then I make pause, and then do the third phase injection. So
Ah,
in order to get the enhancement clearly. So that's
I see. So you leave some of the contrast for later.
yeah.
Mhm, mhm. And then I looked up this. There's a little quick guideline. If you have about a 22 gauge, you can use up to 2 to 3 milliliters per second power injection. If you have a 20 gauge, 4 to 5 milliliters per second. And if you have an 18 gauge, then you can use 5 to 6. Of course, depending on the size and the age of the patient. All right. Excellent question, Dr. Maleva. Thank you very much. And anybody else? I know we've gone over time. Thank you for being faithful and showing up and bearing with us despite our technical difficulties. I'm going to let everybody have a great weekend. In the chat, you will see the Prodigee feedback form. Please stay connected. Join the WhatsApp community so we can keep you updated of upcoming meetings. There's one more meeting coming up in 2 weeks, same place, same time. We're going to try to show you some cases that have to do with chest wall abnormalities and maybe some of their effects on the cardiovascular system. And I think that will wrap up our spring series, and we'll then take a little summer break. So don't miss this last one coming up in 2 weeks. And hope to see everybody there. Make sure you join the Prodigee group. Thank you, Dr. Pinkham, for all your help. Thank you, Dr. Amal, for the cases. And thank you for all of you for participating. Have a great weekend, great rest of the afternoon and evening.